Aspirin plays a major role in modifying platelet function. It irreversibly inhibits the enzyme cyclooxygenase, which blocks thromboxane A2 production. Without thromboxane, platelet activation is impaired, meaning platelets can't aggravate effectively. This is why aspirin is used as an antiplatelet medication in patients at risk for heart attack or stroke. However, the same mechanism also prolongs bleeding and must be considered before surgery or in patients with bleeding disorders. Administration results in this irreversible inhibition, as I mentioned, which effects will last for the lifetime of platelets, which platelets' life cycle is about 7 days. Patients undergoing certain platelet function tests should avoid aspirin for at least 7 days prior to getting their tests done. This is just showing the antithrombo effects of aspirin as reported in the literature. Now, we can measure from a lab perspective serum salicylate concentration in patients with a suspected overdose or toxicity. We want to interpret the results, though, in conjunction of patient's signs and symptoms and acid-base status of the body. The toxic concentration would be anywhere in the range of like 30 to 50 milligrams per deciliter, as the therapeutic dose is between 15 to 30 milligrams per deciliter within the body. Lastly, vitamin K deficiency. Vitamin K is lipophilic. It's a hydrophobic vitamin. It's needed for post-translational modification of our coagulation factors 2, 7, 9, and 10. Um, it involves an addition of a second carboxyl group to a carbon of glutamic acid residues near the terminal end of 2, 7, 9, and 10, which allows for a pocket of calcium that promotes phospholipid binding. Vitamin K deficiency or presence of warfarin reduces these clotting factors, and they're therefore unable to participate in a clotting reaction or coagulation reaction. Quinone, which is kind of the starter component, is found in green leafy veggies, fish, and liver. It's also produced by intestinal organisms. When we assess vitamin K deficiency, it can be determined indirectly by measuring vitamin K dependent factors. And in patients who are vitamin K deficient, the levels of these factors are often 50% less than normal. Phyloquinone levels can also be measured directly, but are impractical for clinical use because there's no real established normal levels for these quinone measures or quinone components. Some sources of vitamin K, green leafy veggies or intestinal flora, what's required for synthesis, causes of deficiency, and then, of course, treatment. The dietary requirement for vitamin K as adequate intake or AI is 90 micrograms daily in AFAB individuals and 120 micrograms daily in AMAB individuals. And for most adults with vitamin K deficiency or coagulopathy, we treat with one dose of 10 milligrams of oral vitamin K. If there's a malabsorption issue or if someone can't take an oral medication, we can administer this 10-gram dose parenterally, either sub-Q or IV based. That's the end of this lecture. Thanks for being patient and me getting it up this week. There was a little bit of a delay, but you'll find that it will lead us down the road to help solve the case. And then next week, we're going to move out of the CBC and clotting and hemostasis and move into other blood serum factors.